We are live now, sir. A very good evening to you, ladies and gentlemen. I welcome you all to this second edition of Spine Connect today, where we have very, very interesting discussions, mainly case-based, and a very brilliant panel of speakers. Shailesh Hadgaonkar, a future secretary of the Pune Orthopaedic Society, has been a very dynamic and very efficient manager for this. He has organized this event so well. I welcome you all on behalf of the Pune Orthopaedic Society, of which I am the president, Dr. Arjun Vegas. And as a member of PASS, which is the Pune Association of Spine Surgeons, I welcome you all to this meeting. There will be very, very interesting cases presented today, and we really are looking forward to having a live, vibrant interaction with you all. So welcome, and let's start the program. I hand over to Shailesh Hadgaonkar for the further proceedings.
Thank you, Mr. President, for giving us this great opportunity. And as we all know, Dr. Vegas is a very dynamic president of Pune Orthopaedic Society, and he is known for his academics as well. He is practicing at Inlax Hospital in Pune for nearly 20 odd years, and he treats a lot of spine, joints, and orthopedics. And his interest is mainly in spine. So thank you, Arjun, for being there and giving us this great platform. And team Pune Orthopaedic Society, Dr. Yogesh Kandalkar, the secretary, and all team. Good evening, everyone. And at the outset, I would like to thank all the viewers for this interactive case-based discussion. And we have our co-convener, Dr. Samir Dalvie, one of the most eminent spine surgeon from Mumbai, is practicing for around 25 years in Mumbai, and he is one of the legendary spine surgeon we all know. Thank you, Dr. Dalvie, for accepting this. And we have a stellar faculty. We have Dr. Samir Lad, who is the academic chair, who is from Solapur. Dr. Ajay Kothari, who is from Sancheti Hospital, Pune. And Dr. Deogaonkar, who is at Dinanath and Sancheti Hospital, Pune as well. So we have a very good faculty from Pune. At the same time, we have very good faculty from all across Maharashtra. Eminent spine surgeons like Dr. Himanshu Kulkarni, who is practicing at Sangli from Shraddha Spine Hub. Welcome, Dr. Himanshu. Dr. Vivek Deshmukh, who is one of the stellar spine surgeon in Aurangabad. We welcome Dr. Vivek, who is practicing at Sigma Hospital. And we have Dr. Sudhanshu Kothadia. He is the first spine surgeon in Solapur and practicing at Kothadia Nursing Home in Solapur. We have Dr. Pramod Bhilare, who is practicing as a spine surgeon in Pune at Sancheti Hospital. And we have Dr. Bhushan, who is working with us as an associate, and we will have some cases from Dr. Bhushan as well. So without taking much time, I would like to start straight away with a case-based presentation. First case, I would invite Dr. Himanshu Kulkarni to start.
Just a second, sir.
Connection issue, it looks like, Himanshu. By the time Dr. Himanshu sets up some internet connection, probably at Dr. Himanshu's side.
I'm very sorry, sir. I'm back. Am I audible?
Yes, Himanshu.
Okay,
Sorry for the technical glitch.
Yes, Himanshu.
Yes, sir. Good evening, everyone. Thank you, Shailesh sir, and thank you, Pune Orthopaedic Society, for this opportunity to be the part of third Spine Connect. Spine Connect has been a very successful series. So I'll start with my case. I'm the opening batsman here. So my case is a atypical, so I won't go into that detail. So my case is 6.5 versus 4.7, a jailbreak in a life-threatening spondylodiscitis. Is my screen visible?
Yes.
Okay. So this is the case. So the case was 78-year-old male, severe low back pain since last 3 months, inability to walk and sit properly due to very severe pain. Patient was unable patient was unable to sleep supine. Known case of IHD, hypertension and asthma. So 78-year-old male, all the comorbidities are there. When the patient came to me, he was already on AKT since last 2 months. But over those 2 months, the pain had worsened like anything. So now the patient was excruciating pain when he came to me. AKT was already going on. So the first MRI, which was done by the primary surgeon 2 months ago, was like something like this. So it was a T2 sagittal where you can see it was a L23 spondylodiscitis with minimum prevertebral and epidural collection. There is no big collection there. You can see the edema in T1. It is extensive osteitis at L23. So it is L23 spondylodiscitis. You can see there is edema in psoas, which is left more than right, but no collection as such. So it's a very initial stage spondylodiscitis at L23. So now when the patient came, so this was the first MRI 2 months ago. Now this MRI was seen by the primary surgeon and the patient was put on AKT. No biopsy was done, no tissue diagnosis was there, but the suspicion was AKT was there, of TB was there. So he was put on AKT. Now the patient came to me with an inability to sleep or walk or sit with excruciating pain, which has increased over last 2 months.
Just a second, Himanshu. Just a second. I would like to ask the panel of expert, Dr. Dalvie, how often you start something looks very classical TB, but not biopsy. There was no biopsy, and how often you start your AKT in such situations?
Very, very rarely. I will not start AKT. I will not start AKT without a biopsy. In any circumstance. In this circumstance, though, not at all. Because firstly, he's an elderly guy. Okay.
Yes.
Maybe immunocompromised. And that MRI doesn't look like TB at all. It is more of osteitis. It's not, can't see any big abscess or anything of that sort. So there is something funny going on there. So I would not start AKT. I would only start AKT on a patient who's absolutely not willing for a biopsy.
Or somebody whose biopsy has
alternatively, you've got a patient who's got full-blown pulmonary TB, cough somewhere else, this, that, and the other, and then he has a pulmonary and he has a spinal lesion, then it's fine. That would be maybe one of the circumstances.
Agree.
Okay, the message is clear that we should prefer to do biopsy because there are various different organisms can be there, and we should not jump on directly starting, despite it looks like infective spondylodiscitis mimicking COX. Okay. Yes, Himanshu.
So this was exactly what we were talking about. You should not start AKT without doing a biopsy or without having a tissue diagnosis. So the AKT was started 2 months later when the patient came to me for the first time, where he had already taken 2 months of AKT. This was the picture. So now you can see now instead of 2, now 3 discs are involved. There is gross epidural collection. So you can see there is bilateral psoas collection, which is very huge, large bilateral psoas collections. Now it was L23, now it is L12 and L3, extensive osteitis. And in axial cuts, you can see it's pus everywhere. It's a sea of pus which is surrounding the spine. So this is what happened to the patient. That's why he's in such bad pain and excruciating pain. And the AKT has obviously failed. So now when this patient came to me with this picture, I was very happy. You know, surgeons are always knife crazy or surgery crazy. So when you see these type of cases, the surgeon inside of you always awakes. So you always think I'll do a nice surgery, a heroic surgery. I can display this case. I can put this on Sancheti core group. Everybody will praise me. It's a surgeon instincts. It always is there, which kicks in when you get a challenging or a bad patient. You want to excel in that. You want to do a nice surgery and you want to go ahead. So naturally, I wanted to do that. So I was in search of a heroic surgical outcome. So this is what I wanted. So I should get a very nice heroic outcome. It should be a heroic case and I should feel very good about it. So I wanted to pose this patient for surgery. But my heart was broken very early. So this was the picture. This was quite expected looking at the amount of pus that is there. So HB was 9.1, ESR was 80, CRP was 130, TLC count was 18,400, SGPT was 358, SGOT 290, alkaline phosphatase was 280, and INR was 6. This was the highest INR I had ever seen of any patient in my life. So INR was 6. So clearly that AKT was not working for him, and side by side it was killing him. So he was in early hepatotoxicity because he could not tolerate this AKT. So this was a grave medical picture. So obviously this patient was not fit for surgery. So it was a heartbreaking scenario. I could see my heroic outcome going slightly away from me. It was still close to me, but it was going slightly away. So I still had my nerves under my control. So I decided, no, we have to do something. Let's get the physician involved. AKT, obviously, it had to be stopped immediately. So physician started him on injection vitamin K, and injection linezolid 600 BD started empirically in view of raised TLC, because the patient was he was not in septicemia, but 18,000 count was not something very good. So he started him on a broad spectrum antibiotic, which was linezolid. So my plan was still on. What next? We have to do this heroic. We want this heroic outcome. We have to go for the surgery. So plan was give linezolid for 7 days. You can bring the TLC count down. Then let the liver heal. So it will bring the LFTs down. Then pray for the anesthetist to be in a good mood to give fitness for this patient after 7 days. And if he is in good mood, if he gives a fitness and if everything goes well, then plan the surgery. The plan was very simple.
Himanshu, I have a question.
Yes,
I
sir.
have a question. When one of the first statements was that this patient was treated without a biopsy.
Yeah.
At this stage, why did you want to not do a biopsy? Why did you want to jump to surgery? Like your
Sir,
whole movie scenario all accepted. Other than that,
no, I'm coming to that again. So
no, you're not. No, you should have just done a biopsy, no? Instead of planning a whole movie around it, you should have just.
Yes, I'm coming to that in next 2 slides.
As to why you didn't do a biopsy.
No, I'm coming to the biopsy and why I am going to a biopsy.
Okay.
Now, my question is, why didn't you think of biopsy first? Why did you want to directly go to surgery?
Yes.
I mean, you may be having some reasons.
For dramatic reasons, nothing else, sir.
Just
for dramatic reasons, that's all.
Okay.
So I did go for a biopsy first. I wanted to explain the scenario first so that the take-home message is taken in some way. So I am going to do biopsy right away. So when I go, so to make the patient, sir, first reason not to go for biopsy immediately on that day was INR was 6. So I was not very comfortable. So I wanted the INR to come down and then go for a biopsy. That was the initial picture.
Okay.
But by the time the INR was coming down, this all was happening. So linezolid was started. INR had to come down because I was giving him the vitamin K. So on day 2, when I went for the rounds in the ward, this was the picture. The patient told me that I have these lesions all over my body. So these were the patechi. So this is the photograph of his left hand. So this was all over his body. So this was again something baffling which I came around. So I didn't get an answer to this. So now when I did the blood investigations, now the platelet count was 40,000. INR had come down, but the platelet count had also come down for something to get the biopsy done. So patient had no fever, no prodromal symptoms. Dengue IgM and IgG was negative. Now platelet count 40,000, INR 2, no fever, no other symptoms, but the platelet count is 40,000 now. So how should we go ahead? Even if I have to plan a biopsy or aspiration with INR 2 and platelet count 40,000, and I have no reason for platelet count to be 40,000. So what should be the reason and how should we go ahead now?
Take an opinion of an ID specialist, see what he has to say.
But again, the biopsy would be required in this case.
Absolutely.
So I would go for, one thing I just wanted to mention was, in the history, in a short nutshell, we write IHD, DM, hypertension. And if you go and really ask them the history, it will give you a lot of clues, especially if IHD, what IHD has to do here, whether angiography was done, angioplasty was done for the patient, and it has some bearing on the present situation or not. Sometimes patient says he had a history of episode of pneumonia, but we neglect that, and we as a clinician, as you rightly said, we as a surgeon jump on the knife easily. We go to the knife easily, but going to the history of such patients will really give you a lot of clues. So this, whether the angioplasty was done, because there are certain organisms associated with angioplasty, and that can have a presentation what you have right now. Also, the biopsy would be the next go-to investigation in this case. I agree with Dr. Dalvie sir, what he mentioned, that no doubt
biopsy would be done, but with INR 6, would you be really?
7 days. So in this case, I would wait for 7 days, optimize the patient.
That was the plan. Wait for 7 days, get the INR down, let the liver heal, and then go for it.
Yes.
In this case, angioplasty was done, but it was 7 years ago. And currently, he didn't have any history of previous infective period. So UTI or anything like that.
Himanshu, can I ask a question? With such a
Yeah,
large
yes, sir.
pus abscess, why did you think of maybe a USG guided aspiration, which can so
Yes, sir.
easily be done?
Anything to be done. So biopsy in this case was absolutely USG guided aspiration because you have a
Yeah,
pus there. But with
yeah,
INR, no radiologist is going to touch him. So it has to come down.
yeah. Because I think in a chronically ill patient who has been, having liver function failure, who's been having a count of WBC count of 18,000 odd, I think he's going into, multi-system failure. And this WBC along with this thrombocytopenia that he has just got, I think it's all correlating and he is just, collapsing. So what next, Himanshu, now?
So now,
Did you do Brucella antigen, by the way?
yeah, Brucella was negative, sir. It was done previously also. Brucella
And blood culture? Blood culture?
So, coming to that. So this was the picture, and this was just a point to be shown to you. So when I spoke to my physician, so this is a very common known thing. So this was linezolid induced thrombocytopenia. So we use linezolid very commonly. So this has got nothing to do with multi-system failure. Actually, I also felt so. So this was linezolid induced thrombocytopenia, and this was a new thing to me also. When my physician told me, I went into the literature and I got multiple papers which say that some people, when you give them linezolid on day 3, they go into thrombocytopenia. So this was linezolid induced thrombocytopenia. So now I have thrombocytopenia. I want to go for a biopsy. I have INR of 2. I had to stop linezolid also. So now what next?
And giving linezolid also had no means. I am not a physician. And I think there is I am assuming Dr. Pramod is a physician. But giving linezolid without any evidence doesn't make any sense. I mean,
Absolutely.
because the count is high, giving linezolid, in what sense does that make? I'm sorry, it doesn't make sense to me, but anyway.
No. So it doesn't make sense. That's what I'm saying. The mistakes which were done during this and which should not be repeated. That's the whole thing. Yeah.
Yes.
So another point, sir, since you mentioned, if you are, another point of not giving linezolid is used as a second line drug. So if you're stopping AKT, if it turns out to be MDR, and if you're using another drug, which is a second line drug, so you are again making that weapon blunt. So this is again a mistake. I'm going to point out all the mistakes which are done during this. So linezolid, it should not be started like this because you don't have a tissue biopsy. Absolutely true. Second point which I want to make, if I have started linezolid according to my physician's opinion, it was a second line drug. So you should use second line drugs very cautiously. So now plan USG guided aspiration. Now we stopped linezolid. The platelet counts came slightly up, so it were good. INR settled. Now I planned USG guided aspiration 72 hours after stopping antibiotics, because if he was on antibiotics, the culture would have been negative. So 72 hours after stopping the antibiotics, we planned to go and did exactly the same. That was what was planned. Diagnostic and therapeutic USG guided tapping. So when the radiologist went in, he could not aspirate a lot of things because he told me that the pus is very thick. There are multiple loculi. He did multiple attempts. He stabbed a couple of times on both sides, but all he could aspirate was 2 ml of pus, because he said it is too thick to aspirate. You cannot do anything about it. And there are multiple loculi. I am not able to. I entered multiple loculi, but only 2 ml could be aspirated from one side out of that huge pus, but supposedly it was very thick. So only 2 ml could be aspirated out of diagnostic and therapeutic USG guided tapping. So this 2 ml pus was sent to my microbiologist for culture. Culture was negative after 72 hours of incubation. Gene expert negative, gram stain negative. What next? I could see my heroic outcome slipping out of my face now. So everything is negative. I could get only 2 ml of pus. I don't have the diagnosis. I don't have tissue diagnosis. The pus is still there. Patient is still not very good. What next?
Yes, what you will do, Sudhanshu, in this situation?
Very tricky situation. Everything is completely against you. So I think definitely go inside and do the surgery and take the material inside and again send it for the recultures and everything after the fitness. That is the, I think, option What is
Yes,
left
Pramod.
for you?
Yes, sir. I think the problem here is the sample. Sample sent was the liquid sample, which is the pus sample. Now the problem with this pus sample, in fact, one of the paper from Dr. Hadgaonkar is a co-author for that. That we have sent it, the gene expert will always come negative because it has a very less sensitivity when you send a liquid
Liquid.
sample. If at all you want to send, you send a tissue sample, and I think a bone biopsy would be the next thing I'll do in these cases because tissue sampling yield is way better than your liquid sample.
Dr. Kedar.
No, I think we need to make I think the with so much of us there, saying that I could only get 2 ml doesn't make any sense. You have to
Will you
use
repeat
a
the
wider
biopsy?
bore needle. You need to have a wider bore needle or whatever it is. Maybe, whatever. Or like do a small, very mini retroperitoneal thing. But you need tissue. I think this case, there is no discussion in this case unless you have a tissue diagnosis.
Yeah.
Samir sir, in short, change the radiologist.
I don't know about that. You need to get tissue diagnosis. That's all
I
I need to
actually
do.
did that. So, for better
Yes,
tissue
Kedar.
diagnosis.
Hello,
Yeah.
you can hear me?
Yes.
Yeah.
Yeah. So I think everything rests on the diagnosis, what this pathology is. So sometimes even I would think of putting bilateral pigtails, and then you keep on getting sample because there's so much collection in that psoas, which to ana hi hai, you'll get, and then you can see what, we need a diagnosis. Otherwise, we are just going nowhere without a diagnosis.
Absolutely. So
Yes.
it was a Mentos moment kind of. So as I actually changed the radiologist. So I went to a senior radiologist. Because this was eating my brain, I consulted him. But during the discussion, he told me though, even though the pus is thick, you just insert a large bore pigtail catheter. In your surgical field, you must have seen that in a fat patient, when you put a foreign body or implant inside, there is liquefaction of the fat. So it is not a documented fact, but I have seen in my practice that if you put a foreign body in a pus material which is thick, the pus liquefies and it starts flowing. I was not very convinced with that, but I had no other option to go. I was not very comfortable operating this one with such comorbidities. So he just told me that insert a large bore pigtail, let it be there for a couple of days. The pus will liquefy and it will start draining. I had no other option, so I went ahead for that. It works like fat liquefaction at operative sites. You see that in your surgical field, so it works in here also. So I believed him. We went ahead with the procedure. So we did 2 large bore French catheters bilaterally, pigtails. So 4.7 mm diameter is the largest one available. So we put it bilaterally. Day 1, there was nothing. I was losing my patience. Day 2, there was 50 ml collection bilaterally. By day 4, we could drain 600 ml pus in toto completely from both sides. And other than that, the most important and most exciting news was I had fresh and ample sample now. So we could aspirate from the first aspirate, and I had ample amount of sample now. This time I didn't repeat that mistake. This time so this was the experience which saved my day. So he was a very experienced radiologist. He had done some procedures like that, and he had seen things happening like this. So experience saved the day. Now I didn't make the simple mistake again. This time I involved an infectious disease specialist. Unfortunately, I don't have one at my place. I have to consult one in Pune. So I sent the sample to him. He processed the samples. All samples were processed by him. But once again, the culture was negative. Gene export was negative, and everything was negative. Now what? But now, since he was an infectious disease specialist, he had a special trick up his sleeves. So what we did for this one was genomic sequencing. So genomic sequencing is genome sequencing of infected material by reverse genetic engineering DNA of the organism in identify. The organism is dead, but you can identify the organism, the dead organism, by reverse engineering. So reverse RNA technique, you can identify which organism is there in the pus which is already dead. So the benefit of genomic sequencing is you never miss an organism. It could be bacteria, mycobacteria, or fungus. But the limit is you cannot do sensitivity because the organism is dead. You can just identify the DNA sample and identify the organism, but that cannot show any sensitivity because that is already dead. So this turned out to be Burkholderia pseudomeli. So he actually messaged me this. the way I had studied in my second year for microbiology, this actually went bouncer for me. So I was like, what? He was like, I'll just WhatsApp you the name. So it turned out to be Burkholderia pseudomeli. So no sensitivity. We didn't have sensitivity, obviously, because this came out of genomic sequencing. But then again, he told me that I have experienced some Burkholderia infections in some renal transplant patients. So I have seen them responding very well to flucloxacillin. So we gave him injection flucloxacillin 500 mg QID for 1 month. So we did third MRI after 1 month of IV flucloxacillin. So from this, the picture went to this. This was after 1 month. So from this, a pool and large sea of pus, the picture went to this. And you could see pus everywhere in the sagittal cuts. It turned out to be this after 1 month of IV flucloxacillin. So once again, the experience saved my day. We didn't have the culture. We had the organism, but we didn't have the sensitivity. But the experience of that infectious disease specialist saved my day. So I could see my heroic outcome coming back to me slightly. So the blood investigations at the end of 1 month where HB was fine, ESR was 30, CRP was 22. Rest all the counts were okay, and INR had come down completely. So INR was 1. So plan then, 1 month of IV was done. Then we had no sensitivity. This was absolutely going according to his experience and his call. So he told me to put the patient on tablet chloramphenicol, 2 tablets, 500 mg QID for 6 weeks. Weekly RFT monitoring. RFTs turned out to be fine. So after 2.5 months of antibiotics, this was the picture. Absolutely fine. You cannot see a blue highlight anywhere. Everything is okay. So this was the patient at the end of 2.5 months. So 4th month MRI, it actually had no role, but I had to do this for documentation purposes. So 3 months after stopping all drugs, this was the picture. So complete resolution of disease. In axial, in sagittal, you cannot see pus anywhere, and the disease is completely healed. So I could finally get my heroic outcome, though not surgically, because that was not really possible, but I could actually get it. So the crux of this case is surgery is not always a final solution. You should not always think about surgery. A 4.7 mm pigtail saved the day, and not a 6.5 mm corticocancellous screw, which was to be put in this porotic patient. Medical management is not our cup of tea. Infectious disease specialist is the most valuable asset in a spine surgeon's team. And do not try to play solo. Involve people, take opinion. Their experience is only going to help you and make your case better. So, thank you.
Thank you, Himanshu, for a brave presentation and a lot of learnings, what you have learned. And I think one message is very clear. You have to do biopsy. And if the biopsy is not yielding anything, you have to try one more biopsy and you will get the answer. I think we have spent a good time on this. We'll quickly move on to the next presentation by Dr. Sudhanshu Kothadia. Over to you, Sudhanshu. We have a couple of rapid fire cases also we have kept. After this will be Dr. Kedar Deogaonkar.
Is my screen visible?
Yes.
Okay, is it visible now? Okay.
Perfect.
Yeah. So thanks a lot, Shailesh sir, Samir sir, for this opportunity. So we are discussing with the infections. Being an orthopod and spine specialist, we have to deal with the infections in our day-to-day life. So presenting the case of MDR, pyogenic infection. So it's like a MDR cox. Now it is a MDR pyogenic infection. Okay. So clinical scenario, a 65-year-old obese male, stout. He presented with the history of trauma. The crux is that he was admitted at some another hospital and they have done only basic X-ray, which he was not having. And he told me that he had a trauma twice. He came with a back pain, tossing in bed, typical presentation with the pain. Hypertension, diabetes, CKD, liver cirrhosis, IHDO, full-blown, all your comorbidities, tobacco chewer, alcoholic, and he was not able to stand and walk because he was paraparesis, also grade 3 power in the lower limbs, mainly knees and the ankles. So when I revealed the history, he was not having any investigations carried with him. He was admitted somewhere hospital for 3 to 4 days, and he told me he had repeat fall he started to get up from the bed. He again fell down, and then he not able to stand and walk. This was a clinical scenario what he presented to me. So it was the X-ray which I did, and then actually I did the MRI. First time I did the MRI because MRI was not done previously, though he was admitted, transferred from 2 hospitals. So the MRI was clearly showing us the pathological collapse, and the bright disc signals adjacent 3-4 at 4-5, mainly at the 3-4. And axials is also old age, so we are seeing some stenosis and everything. So
let's ask.
Yeah.
Let's wait. Sudhanshu, we'll just ask Ajay. Ajay, are you there?
Yeah, I'm there.
So what is your next plan, Ajay? Now, this patient is in front of you, so many comorbidities, and you are seeing the X-ray and MR.
Yeah. So I would do a biopsy for him. I would do a transpedicular biopsy, and I would go from 4 pedicle and direct my needle into L3-4 disc space and L4-5 disc space and try to fetch as much sample as possible. But I would go for a biopsy.
Vivek? Dr. Deshmukh? Dr. Pramod?
Yeah, assuming that the blood investigation is done and will definitely show a raised GSR CRP.
Yes.
Biopsy would be a go-to procedure in this case.
Fortunately,
But
all other investigations were normal, including his cardiac markers.
I am very surprised because being CKD patient, usually they have a ESR, CRP, and even create everything at a higher levels.
Create fortunately was not more than 2. ESR, CRP was raised, and rest other things, including INR. It was good.
Only thing is biopsy for sure, but in this case, specifically in this case, he becomes a high risk for a fungal infection also. So if at all I have to do a biopsy and send it for culture, along with the doing a Brucella antigen for this case, I'll definitely do pyogenic TB as well as the fungal culture and staining.
Okay. Yes, Sudhanshu.
Yeah, so basically I didn't offer biopsy at this stage. I decided to operate this patient in view of neurodeficit and the pain. So I operated with this patient, removed almost 30 to 40 cc per centrof from everywhere, like a disc space from the paraspinal gutter. So initially I was decided to put a cage, actually interbody, but seeing this so much of pull of pus, I actually abandoned the plan of case. I just extended 1 level above because he was very stout, obese, and I packed the space with the bone graft. So this was the post of X-ray. Culture reports, all the culture reports were with the Klebsiella pneumoniae. And the main thing what the report was, everything was mentioned R. It's all resistant. You will see 1 or 2 drug like a colistin, polymyxin B, and some intermediate. So the actually saga started right now because you have done the surgery and you have this report with us. So I involved basically ID specialist from the beginning and with my physician. So I discussed with the case with my physician along with ID specialist from Pune, as well as the patient's relative were having some connection with the Mumbai also. So at ID specialist, we have the meeting, actually telephonic conversation for 45 minutes, how to go ahead with this patient. So they started, I was actually following just their instinct. They started on the tigecycline, meropenem, initially colistin 2 and polymyxin actually was the backup plan if it fails. So tigecycline, meropenem, colistin was the first drug of choice what they started. So pain started reducing, in-bed turning was becoming pain-free, in-bed lower limb exercise started. So actually I was getting a bit relaxed कि चलो ठीक है, antibiotics are working, काम हो गया है, I think keep cross finger he will come up. But it was not my destiny, I think. So it was the post of day 7. The wound started.
Sorry, I've got one question. What
Yeah.
was your indication for surgery? I didn't understand why you wanted to operate this guy.
Sir, I operated for the surgery because of pain and the weakness. He was having paraparesis, both lower limb. So I decided surgery for that.
He didn't have that much compression, no?
Yes, sir. Yes.
Okay.
Maybe,
Because
maybe
especially in such a
dynamic.
high risk patient, I mean, like I said, the first dictum still remains. You should have, I mean, I would have got a biopsy first.
Sir, it was a high risk case. Fortunately, I got the fitness from those anesthetists as well as cardiologists, so I actually decided to operate.
Maybe pincer and maybe a dynamic compression could be the reason for neurodeficit.
Okay.
That, yeah. Okay. Yeah.
So this was his wound on post-op day 7 with you can see the serosignous discharge from the wound with the angry wound, erythema, margin collection. So what now? Wait till this subside, imaging, debridement, implant status. These all questions were in front of me. So what the panelists will choose at this stage.
Nikhil, Dr. Malewar from Nagpur.
Yes, sir.
What next?
You will wait and watch till this gets subsided on its own, or you will go inside and debride, you will do imaging, means what kind of?
I think you should have done the biopsy first, but now this status, I think you should wait and continue some antibiotics.
We agree now, yes.
And again,
I think you should continue antibiotics.
Yeah, you can see the culture, means I have attached the culture reports because I see the wound swab stick also. It is again showing the Klebsiella pneumonia.
Dr. Vincent.
Yeah, so same organism. I think you can continue with same antibiotics.
Dr. Vivek, Vincent.
Yeah, Sudhanshu, I think maybe now we should consider imaging, find out exactly from where the pus is coming, whether the collection is increased or not, and take it forward from there. So first imaging.
Yes.
Dr. Deshmukh?
Yes, sir. Still, at this stage, probably I'd like to go in and debride the pus, all which is there, and I'd like to resend it for culture again.
Okay, let's see.
Because it's like a busting abscess. At some point of time,
if you carefully look at the abscess in the black circle, it looks not very good.
Yeah. You need to do something for this.
Yes, Sudhanshu.
Yes. So I did the imaging. I did repeat imaging, X-ray with the MRIs and everything. And as I rightly picked up, MRI was showing all the intensity were increased, and now it was the abscess formation. It was there in the bilateral psoas muscle, more on the left side and the right side, and it extends in the posterior spinal muscles also. So I did this post-op imaging, had a good radiologist, discussed with the radiologist, and again we planned for the pictal catheter for the left psoas muscles. Definitely debridement for the posterior wound, but before debridement, I planned for the pictal catheter from the left psoas, and we could able to take out a good amount of pus from there also. And after that, I went inside, debrided that, and I did this debridement with my dad, Dr. Kothadia. So elliptical removal of the incision, following all standard protocols of the debridement. And we put actually bioabsorbable cement beads, because till now I was having the culture reports, even the psoas abscess was showing the same Klebsiella. So every single sample what we are getting, we are screening through all gene expert, fungi, aerobic, anaerobic, everything, to doubly sure are we dealing with any other organism or we are having the same hurdle. So we use bioabsorbable beads, it's stimulant, and we put the antibiotics with antibiotic impregnated as the told by our ID specialist. So finally that patient started improving after the debridement. Luckily I did not did any third debridement for that. So he started, wound started settling, and I did the follow-up MRI. MRI also shows that the complete resolution of the abscess and psoas muscles. So finally, after the physiotherapy, because having the limb weaknesses, initially I was feeling that limb weaknesses is just because he's lying down, and because of the pain, it's like a pseudo paralysis. But once he started pain-free, then actually it was a weakness of the both knee. As he was not able to stand, there is a lurch when he's standing. So started with the rehab, physio, everything. The story goes long, and finally he able to stand on his feet and he's started to walk. So actually he's the owner of dance bar. So he was very happy to enter into his, profession after, 3 months almost after the extensive physiotherapy. So take home message actually I would like to put, don't wait to get an MRI done if patient is not improving, because when he visited to me, it was only the X-ray and they were just treating, the pain. It could be the X-ray showing some kind of fracture. They were just treating like tractions and all IV painkillers and everything. So please don't hesitate to get the MRI done as early as possible. If your patient is not improving with the treatment, what you are giving, what sort of treatment you are giving, that doesn't matter. But please investigate. Don't hesitate, as MRI is a gold standard to reveal many things. Treat every infection aggressively. Here, actually, I don't, like to wait and watch policy, as Vivek Deshmukh sir spotted, Shailesh spotted, it was not looking that good. So actually treat every infection aggressively. My father always say, attack the infection before it attacks you. Involve physician, ID specialist, chase physician as per the availability at your place. So as Himanshu told, don't treat everything on your own. You are a surgeon, spine surgeon. So have a good ID specialist, at least a good, sensible physician who is updated regularly with the newest antibiotics, newer antibiotic protocols, organism. So involve them in your team and make your life easy. And don't start any empirical antibiotics or any AKT without tissue diagnosis. So just don't start seeing the MRI, it is the pus. Don't start directly AKT, because not every single pus or not every single infection is a TB. Thank you so much.
Nice case, a lot of learnings, a great discussion. Thank you, Sudhanshu, for a wonderful case. We move on in view of time to the next case. We have Dr. Kedar Deogaonkar from Pune. Over to you, Kedar.
Yes, I'll just share my screen.
After this will be Dr. Nikhil Malewar. And 2 rapid fire, that's it.
Okay, can you see my screen?
Yes, Kedar.
Okay, good evening, everybody. Thanks to Dr. Hadgaonkar for inviting me for this program. So I'm presenting another case in the same theme of infection. A 57-year-old male presented to us. He had history of COVID in 2022, for which he was put on steroids. So this gentleman was a bald gentleman for a long time, and he used to wear a wig, regularly change it and all. And recently there was some new model of wig which was introduced in the market, which he had recently started using. And it needed a meticulous hygiene, which he was not following regularly for the application of the wig. So he had another problem. He had an Epstein anomaly of the tricuspid valve, which means it's a bicuspid valve, and there is some cardiac issue with that. Apart from that, he did not have any other comorbidities. So he presented to the plastic surgeons with fever and necrotizing infection of the scalp. And he was admitted to Dinanath, and he underwent multiple scalp debridements. So he was admitted in November 2023, and he stayed in the hospital for 3 months because of this scalp infection, needing a lot of care and repeated surgery. In the hospital, he had a stormy course, regularly on and off fever he was having. He also had altered sensorium. So then they focused on CSF study, and they were thinking that maybe that infection has gone into his CSF, or he is having some encephalitis through the communicating veins. They did a lot of detailed studies, including a biofire assay, which was negative. But then they went and did calcofluor staining of the wound, which showed fungus-like organism. Blood and urine culture, CSF culture were negative. And throughout his initial stages, CRP was 150 to 200, high white cell count in the range of 16,000, ESR was 100. So scalp swab showed mucor, and also later on when the fungus got control, he also had Klebsiella on top of the mucor, for which he was started on amphotericin and isofluconazole. It's continuing for 1 year. So this was his infection of the scalp, which shows extensive necrosis and loss of full thickness loss, and in some places his skull is exposed. So this is what they were doing regularly, debridements and skin grafting. But then 15 to 20 days after after the admission, he started developing weakness in his legs and also some mild back pain. But the focus of all investigations was so much on his brain, and spine people were not involved initially. And after a week of this back pain and some leg weakness, he was unable to walk. A brain angio MR was done, and again, that didn't show anything. And eventually, they were wondering what is happening. There might be some other focus of infection. And then a PET CT was done, and then suddenly the focus shifted to his spine. So you can see his PET CT picture shows a huge high signal in his lumbar spine, and that is when they involved the spine team. That no, boss, he's having unable to walk. PET CT shows something happening in the lumbar spine. So come and have a look. So that is when we got the call. Obviously, they had not done an MRI of the spine. So immediately, I asked them to get an MRI of the spine. And you can see the images which show collections in the psoas bilaterally, collections in the posterior spinal muscles. There is a small epidural collection also. And, the disc space are not that much involved. It is mainly the muscle involvement and the L4 bone involvement and an epidural abscess component. So this was his X-ray, which didn't show any significant collapse or any disc involved. So basically, we did an urgent decompression. Fixation was avoided. The pus intraop was black in color. So I have the pictures, but I couldn't get it for the talk today. And it grew the same mucor species which was grown from the scalp. So gradually the power recovered, and now he's walking with a walker and a foot drop split. So the message I wanted to give through this short case was, for any physician or any other person, when you're doing a detailed brain MRI, always do a full spine screening. Like we do for lumbar spine, there's always a full spine screening by default. So I told the neurology colleagues and the ID colleagues that if you are, wondering about weakness in the legs and upper limbs, always spine screening has to be included. We could have saved 1 month before getting the diagnosis. Mucor is very rare in the spine, but some cases are being reported. And if there is mucor in the scalp and he's got paraparesis, you need to suspect a mucor in the spine also. So that is the short message from this case. Thank you.
Dr. Dalvie, any comments?
No, excellent case. Much to learn. I think the most important thing is that as soon as there was a deficit, they should have involved the spine surgeon and done an MRI of the spine. But better late than never. And I think Kedar.
Yes, I can hear you.
Decision.
No, we lost you, Dr. Dalvie.
Sorry, you lost me? You can hear?
Now we can hear you again.
Yeah. So what I'm saying is that it is important to involve the spine team, especially when there is deficit, and do an MRI of the spine was one lesson. And most...
Again, we lost you, Samir.
Kedar did a very good thing by not putting any implants. So otherwise it would have been a disaster. So he's done very well with that decision.
Yes.
Okay, perfect. And at the same time, psoas is not only TB. That's a clear-cut message coming from all this. That's very, very important for all of us.
Thank you.
Perfect. Very good case. Very good case. Very interesting. Lot of learnings, and they are opening our eyes. Despite of so many years, we are seeing so much of different organisms. I must have seen at least 12 to 14 different species other than TB in my own practice. So I think a lot of things are really coming.
So one message for the audience is 3 cases have been presented. None of them have to be TB. So when it comes to spine, not everything is always TB.
Yeah, that's
the message for everybody who is listening to this.
Yeah, can I ask a question to Dr. Kedar? What made you not put implants? What was the reason?
So the patient did not have any obvious. We also looked at the CT, which was done as part of the PET CT. There was no major osteolysis, and his main complaint was this burning sensation in the legs and weakness in the legs. So he was not complaining more of back pain. It was not like instability kind of pain. So his main thing was neurology, neurodeficit. And the other part of the story is if there is an unknown organism, or I don't know the sensitivity well, I really think 10 times before putting implants, because I have burnt my fingers. Sometimes even if you don't put implants, at the most we can keep them on bed rest. But if you have an unknown organism or a virulent organism, like if this was NTM, say it was non-tuberculous mycobacteria, implant is the last thing you want to put in an unknown organism, or an organism where we don't know how it will behave. The fungus also, they take a long time to clear, and if they get hiding places in the body like implants, then again they will stay there for longer. So eventually you might have to come out, bring the implant out for a total cure. So yeah, so that's why unless I'm really pushed, I will not put an implant unless I can see an obvious collapse, kyphosis, subluxation, translation, something like that. Shailesh, what do you think?
No, I completely agree. We have to be very careful when there is some kind of such uncommon infection is seen, and signs of instability are very, very important. In this particular case, I think there was spondylitis. There was not much of a spondylodiscitis, which if it is there, then there are chances of more collapse. And that was a very good decision. There was not much of a lysis. Bone was quite okay. We can actually, it's like doing a minimal, do less and do less harm, minimum decompression, identify the bug and treat. We can definitely fuse it if it is needed at a second stage or when required, but otherwise you can actually get away with this. In a lot of instances nowadays, people are doing minimally invasive decompressions or endoscopic decompressions, doing lavage and really coming out of it and treating that with reducing the load of the organism, at the same time getting the culture and treating it very safely.
Thank you.
Any additional inputs, Ajay, from you on this case?
Hi. So I feel that two things that I personally learned from the three cases that were presented till this time. Number one was, biopsy is a must. You can't assume things in today's era, and you have to go ahead. And all these three patients were, immunocompromised. These patients were elderly. These patients had so many comorbidities. So I think that was one important learning, that a TB patient would be having a cold abscess. He would be a young middle-aged person, and he would not be toxic till the end, and there would be a huge collection. So I think Pyogenic comes with a special presentation. That was one. And second thing, I agree with Dr. Kedar. I think putting an implant in a case where you don't know what the bug is, especially a gram-negative organism or a weird fungi, I think staying with only decompression was a good choice.
Super. Let's move on to the next presenter. Thank you, Kedar, for a wonderful case. Dr. Nikhil Malewar from Nagpur. Yes, Nikhil.
Yes. Good evening, all. Thank you, Shailesh sir, for giving me this opportunity. So I'll be presenting a case on. So finally, we come to pod spine case. So can you see my screen?
Yes.
Okay. So this is a case of a 24-year doctor girl. So she was complaining of mid-back pain since 1 year. Both lower limb radiating pain, difficulty in walking, typical history of evening rise of fever, weight loss, loss of appetite, and difficulty in passing urine. So she was on medication for like 1 year. Nobody investigated her for 1 year. No X-ray, no MRI was done. So she presented to me when I see her in clinical examination first. So she has some weakness in lower limbs, like grade 3 power in both lower limbs. The sensation was reduced, reflexes were exaggerated, and the clonus was present. So I obviously I sent her for MRI, but by the time she came back from MRI, she had grade 0 power in both her lower limbs, and sensation was reduced, and her bladder bowel was now involved. So the MRI presentation was this. There was complete collapse of D4 with toppling, and there was significant cord compression and a kyphotic deformity.
The neurology was paraplegia?
So Grade 0.
Okay, okay. And for how many days?
Sir, I saw in OPD, when I see her in OPD, there was no investigation. When I saw her, there was grade 3 power. By the time she came back from MRI, it was grade 0.
Okay.
Within 1 hour, she went from 3 to grade 0. And she was a doctor girl, so this was her MRI.
Dr. Deshmukh, what
So
will
there
be
was a
your
lot of collection.
Vivek?
Sorry, sir. Hello.
What is your plan now? Acute deficit.
Yeah, acute deficits. Sir, definitely deficit at upper thoracic level would like to go in, sir. A thorough, deep, a long segment fixation. As I am, level is probably D5, D6, right, Nikhil?
D4, yeah.
D4, yeah. D4 is the collapsed one, right?
Yeah, the collapse one.
The maximum collapse is at D4.
Yes.
Would like to take a long segment fixation.
Okay.
Let's say from D1 to D6, D7, D8 to that level. Would like to get a thorough decompression by a TPD approach, and would like to put something there for anterior support also. Definitely will get a.
You put a cage.
Sorry.
You'll put a cage at D4.
Sir, something at least a strut graft kind of thing, sir. By transpedicular approach, by a TPD, would like to.
Or maybe only bone graft.
Yeah, bone graft like thing, because looks like D3 also doesn't look healthy. 5 also is.
Okay. Himanshu, what you will do, Himanshu?
So, with such rapidly progressive deficit, surgery right away, no doubt about it. So, the one in between, I cannot make out the level, is completely destroyed. So, I'll go 3 up, 2 or 3 below. And I would like to see what happens on a triangular bolster. If it opens up completely, I may not go for a corpectomy.
Okay, Kedar, any role of anterior surgery here?
I mean, first of all, I would like to point out that such rapid neurodeficit, you should always think of a vascular cause. And if it is a vascular, the TB sometimes will also affect the endarteritis and all that. So, I mean, you just need to tell the patient that, you can't be sure that she will recover even if we do quick surgery. So that is what I wanted to tell over here. Shailesh, I think anterior here probably is not needed because, it is an acute thing. So we'll get decent reduction. And also, I don't think in this D4 region, you really need a corpectomy and cage over here because good rib support. So I would just do a standard posterior, but this is not standard posterior. This is a tough case. So basically, you need maybe another colleague will also be very handy. And don't start this in the evening. Start this case in the morning. Other thing is, sometimes in these cases, I put them on a Mayfield because this can be long surgery. They get facial sores and pressure, things like that. So all these things are important. This is a medico. Maybe we need to take all precautions. And also, I would immediately give her some IV dexamethasone before.
We started.
Protect the cord as soon as possible, as much as possible. So yes, these are some of the thoughts which come to my mind. But primarily, I will not plan for anterior transthoracic surgery. It's very difficult to get at D4 level anteriorly anyway.
Yes, sir. No, I completely agree. Probably you can get away with complete posterior surgery. I will personally prefer to put 3 to 4 levels above and 3 below. I will do a transfacet approach here to go anterior. I will try to decompress because it's a front and back compression. I will definitely try to decompress anterior to the cord, and if I can put in a bone graft, I will prefer to put it there. And only pedicle screw construct long segment should be my plan.
Shailesh, can we ask Samir sir what he would do?
Is he there?
Yeah. So I think In terms of execution of the job, I think there are some things which there is not much to argue about. Number one is that this is straight surgery. This is not a case where you're going to do biopsy or anything of that sort. So you'll just straight ahead go for surgery. The second thing is that the posterior surgery for sure, because of a couple of reasons. One is that there is a dislocation, and the second is the fact that this level is a very awkward level. And through posterior surgery now we can achieve anything and everything which we can do previously through anterior. Thirdly, one small thing for Kedar, and he brought up this point, but the vascular, I will tell you the small difference again because of my experience. The vascular ones are where the sensation is also lost. So if a patient comes back with a motor and sensory grade 0, that is when it is vascular and they will not recover actually. And it's like an acute infarct of the cord. But this patient has sensations are intact. It's pure motor, and her rapid deterioration is because of a dislocation. So her initial issue was because of compression, but while going to the MRI and coming back, the spine dislocated suddenly, and that instability is what has caused the sudden deficit. So if you just stabilize and decompress this, it will be fine. One doesn't have to do very heroic stuff. Like you said, 3 above, 3 below, all is fine. And you do it's TB heals. So don't worry about it. Just stabilize, decompress, don't further destabilize, and the healing will take place. There is nothing to worry. You don't have to think of some very major heroic reconstructions also.
Point well taken. What did you do, Nikhil?
So the other thing is that for this, there is one implant which I use, which this generation may not know, which is the heart shield. So if you want to cross junctions, sometimes the heart shield is a very good implant, because otherwise then you have to use tapered rods and put lateral mass screws and thoracic pedicle screws. So if technically that's challenging to you, then a heart shield rectangle is a very good implant for crossing these junctions.
Yeah. Sublaminar wires and heart shield rectangle. Okay. Yes.
So this was my plan. So I did both posterior and by transthoracic approach. I did the anterior reconstruction also. So I put pedicle screws and 2 above, 2 below, and I put this bullet cage for reconstruction of D4. And this is just immediate post-op X-ray. This is 2-year post-op. She's doing well. She's walking well. She's doing everything.
Sorry, you did anterior transthoracic. You did transthoracic.
No, I did approach posterolateral.
No, transthoracic. Yeah.
Oh. I removed the ring on the left side, and I went there and removed the D4, the pathological part, and I put the cage.
Nicely done, Nikhil. I think.
So I found this T-leaf cages very helpful. These are very easy to put.
All said and done, you did it on the right time. Well, is the best thing which one has done for the patient. Very good, very good, nice. So a lot of things again from this case.
So I put this. The one point. So I put this T-leaf cages. We have these large size cages like 14 or 16 mm. So I put this for like kyphosis, like congenital kyphosis also. So mesh cage is sometimes difficult to put, but these bullet cages are very helpful. You can put them easily, and it's very nice to put them.
Yeah, no, we have more experience with mesh cages, and small size cages also you can actually use. But you can do this, but we prefer mesh cages basically, Nikhil, in this thoracic levels. And corpectomy levels. Nice.
Good job.
Last case of the day, Dr. Pramod Vilare. Yeah, anyone wants to comment on this? Any faculty?
Yeah, so I would like to comment on this.
Yes.
Yeah, so I think we were talking of, going 4 levels above, 3 levels above, crossing the cervicodorsal junction. So I think this is the beauty of anterior reconstruction, that he spanned it just 2 levels above and maybe 2-3 levels below. But having a good strut anteriorly makes all the difference. And along with that, I think appropriate antibiotics. In TB, everything heals, as Dr. Dalvie said. So these are two important learnings. So Nikhil, did you keep her in bed for some time? For you mobilized her immediately?
No, she was mobilized immediately, sir. But she was not able to walk immediately, but she was made able to sit, and wheelchair mobilization all was started.
Okay.
But she was not in complete bed rest. She was
And
because the
you took
fixation was good, so I started the mobilization.
So the hold was good in the top two segments. That's why you thought of, restricting to that level. You didn't want to go maybe 3 levels or 4 levels higher up.
No, so I think anterior strut graph has helped me for keeping the levels low.
Absolutely.
Yeah.
Nice.
Thank you.
Let's move on to the last case.
Yes, sir. Can you hear me?
Yeah, we can hear you.
Slides are seen.
Yes, slides are seen.
So last, I'll keep it slow. It's a night watchman. It is actually the night time. So 55-year-old male, he presented to me with jerk while walking with a history of subtle fall, but he came on a wheelchair, and he had a severe low back pain with a VAS of 9/10, non-radiating. There was a history of night pain since last 1 month. He had a significant history of CKD hypertension, as so much so that he has to have dialysis twice weekly since last 8 years, and also gave a history of sepsis, pneumonia, empyema, for which he was treated in April 2021 for 20 days. On the history taking, there was a pus culture sensitivity during the empyema period, and these were two organisms. This is Acinetobacter baumannii and Candida organism, which was there from the PUMCAT, which was inserted. Fluorosynthesis was done, and history of dialysis was recently done. Examination did reveal much. It was an axial tenderness, SLR was free, there was paraspinal muscle spasm, and neurologically was essentially normal. These were the x-rays, and this is what the patient presented with. And just the patient x-ray didn't reveal much, only apart from the limbus vertebrae at L4 and a diffuse osteopenia overall. I ordered for an MRI because the patient was almost wheelchair bound since last 1 week or so, and the pain was aggravating over the past 1 month. This was the MRI findings, and you can very well see there is a marrow edema, which is T1 hypointense on T2, T1 hypointense, and these were the actual cuts, T2 and T1 again, and the stir revealed a lot of bone marrow changes secondary to CKD and bone marrow conversion disorder. This was the report with the patient. There was minimal edema at the L4 end plate and some at the S1 segment of the sacrum, and the patient had the L4 limbus vertebrae. And these were the labs. I ordered for the labs also for the patient simultaneously. Creat, as expected, was very high, 7.9, and the ESR and CRP were just borderline, not much. Treatment, what he any takes for the X-rays and MRI, anything. Does it look like an osteopathy? Because I discussed this X-rays and also the MRI with our radiologist. These were the MRIs done elsewhere, but everyone reported this as this is most likely because of a fracture and an osteoporotic fracture. He gave a history of subtle fall and a jerk while walking. So, but there was a suspicion that he was having severe pain and also some night pain. I wanted to see the patient back after a month's time. So I did something called as an interval examination, both clinically as well as radiologically. Symptomatically, he was almost same or better after a 1 month. Somewhat better. Initially, he was completely wheelchair bound. Now he could stand, but barely any significant improvement. Clinical examination essentially was saying that this was the X-ray after 1 month. So you can very well see now that the end plate same change on either side at the 3-4 disc, and also associated sclerosis at certain areas. So I ordered for a 1 month later again MRI, and these were the MRI findings. You can see there is progression of marrow edema. The disc space now looks hyperintense on T2. You can see there is some collections in neither of the SWAS. in the coronal as well as the axial cuts. And now the report changed by the radiologist that this now looks more in favor of spondylodiscitis. And the patient lab though showed also an increase in the ESR and CRP, though the creat was every time 7.9. So we planned for a biopsy in this case. L34 spondylodiscitis, a J needle biopsy went from 4, as said by Dr. Kothari. We went to the cranial level, targeted the disc as well as the end plates. These were the reports. The stain was normal. The pink and violet colored slides were almost normal. Rather, they were suggesting of chronic spondylodiscitis, but not pointing towards a single organism like TB or a granulomatous lesion. The gene expert were normal. Pyogenic cultures were normal. The AFB culture for the 48 hours and the 1 week were normal. But the fungal culture revealed the organism here, and it was non-albicans candida, and this was the same organism which was there in the previous empyema case. And we obviously sorted the ID specialist opinion, started the patient on antifungal for 2 weeks, oral fluconazole for 6 months. Now the patient, this is after 6 months, he has lost to follow up after 6 months. I don't know how he is doing, but otherwise almost bedridden patient started walking after a period of 3 months. Now whom to suspect fungal spondylodiscitis? Those who are immunocompromised, having immune disorders, having comorbidities like diabetes, those on parenteral nutrition or IV drug abusers. Now this is in short the algorithm for all the spondylodiscitis, the lab, the imaging. We also do the biopsies. So if there is a negative report, repeat the biopsies. And if once you get a positive report, do a targeted treatment. Surgery is, by the way, procedure most, as in case of TB, this is a systemic disease, a medical disease, and can be treated with just antibiotics or anti-tubercular drugs, and no need to jump your knife and do heroic surgeries or major surgeries in such cases. A short, simple biopsy will solve your problems. Thank you.
Hi, can I ask a question to the esteemed faculty?
Yes.
Yeah, so I think all these cases what we
Yes,
saw
Ajay.
were full-blown infection with lot of abscess, collection. But my question is, when we catch infective discitis early with a discitis element and there is a bony edema surrounding it, there is not much of abscess formation, there is not much of bony destruction. Majority of the times we do biopsy and high probability everything comes negative. What do we do? Do we start some empirical equity? Do we wait, let the infection progress, then do a biopsy, or we repeat a biopsy, or do a surgery? Samir, sir?
I think he has left.
I think he has left at 10.
Yeah, Dr. Kedar?
I would repeat a biopsy if there is no neurodeficit. Then I would definitely repeat a biopsy. If there's a neurodeficit and you need to operate anyway, then we'll get the sample. But otherwise,
any role of open biopsies? Have you ever gone through, doing a microdiscectomy approach, doing a laminotomy, and going ahead and doing open biopsy or maybe an endoscopy?
Yeah, sometimes role for open biopsy is still there. Sometimes if there is a paravertebral collection, then CT guided biopsy is easy. But if there is like an anterior epidural collection, where it is very difficult to reach by CT, or if they have tried CT guided and it's not worked, so or if sometimes there is an intraosseous collection only, then an open biopsy is better, because CT guided, if they have to go into the bone, it is not very easy. So sometimes I go for open biopsy. Yes.
Yes, Dr. Shailesh?
No, I also will repeat the biopsy. That's my first thing. Either a CT, because there are two things. One is a very specific biopsy. If sometimes we can miss it, but if you really want to identify the organism, I will definitely repeat the biopsy. And there are instances, 60 to 70% time we get the biopsy report in the first go. And our experience with the second biopsy, around 10 to 15% patients get the biopsy. And still there is a subset where we really don't get the biopsy. And that's a challenging scenario, what do we do? So I think in these situations, we should have a discussion with the radiologist, we should have a discussion with ID specialist, clinical scenario, and all the blood workup. That will tell us what exactly is happening, and maybe an ID specialist role is very, very important and critical. Sometimes we need to start empirical antibiotic therapy for these patients. And that's unfortunate, but nowadays a lot of new things are coming up apart from gene expert. I think those are really going to be a game changer in future. That's what I feel.
Okay,
Yes,
anybody wants
one
to
more thing,
add?
Ajay, I would like to sometimes if 2 biopsies come negative and the patient is not that unwell, I ask them to wait for 1 month and repeat the MRI.
Uh-huh.
So if there is
And
a
without
fulminant infection,
starting any antibiotics, without starting.
no antibiotics.
Okay.
I would also be of that same opinion. So I have tried it sometimes that you let the disease ripen a little if you do the biopsy, then because most of the times in early phases, it is just reactive marrow edema. There is not a lot of organisms where you can collect it. If you let it ripen a little and do the biopsy.
Interval MRI also is a very important thing. Interval
Yes.
MRI at 4 to 6 weeks. Probably that also can.
Interval MRI and repeat a biopsy then.
Yeah.
And
the
yeah.
blood parameters.
Yeah.
Thank you. I think message is clear. And a lot of interest there. Yes, Vincent, you want to ask something?
I just want to ask Himanshu. Himanshu, you mentioned about an interval MRI and waiting. Now, since maybe the senior faculty can advise patients to wait and maybe patients would listen to them. But people of our generation, or younger spine surgeons, we are afraid that whether the patient will not get better in pain, whether they'll leave us and go to somebody else. So instead of waiting, why not get an open biopsy and get them pain relief?
Absolutely. So I specifically mentioned it that I have tried it in a couple of cases only.
Okay.
So jokes apart, but yeah, that's true. So Ajay sir has already mentioned role of open biopsy. So open biopsy is good, but I have done that in very early infections only. So if it is a kind of mid-infection, abscess is already there, there is no point of waiting. If it's a very early discitis, only minimal marrow edema you can see, you can definitely wait there. And if you give him good pain control, their main complaint is pain. If you give him a good pain control and if the lesion is ripening, so you can absolutely wait.
Okay.
Thank you, everyone. Thank you, all the faculty, the co-chairs and chairs, and Dr. Dalvie for a wonderful interaction and beautiful cases. And thank you, all viewers, for giving us this beautiful time for Spine Connect and Pune Orthopaedic Society, Sancheti Hospital, and OrthoTV for this wonderful academic platform. Looking forward to seeing you soon. Thank you. Good night.
Good night.
Good night.